Hello, welcome to the session. Today we'll be discussing about gestational diabetes. By now, we know the symptoms, risk factor, complications, and preventions of diabetes. So basically, gestational diabetes mellitus is defined by hyperglycemia that is diagnosed during the pregnancy. Gestational diabetes mellitus is divided into two classes. The first is diet control gestational diabetes mellitus. You can control this type of diabetes by controlling your diet. And another class is gestational diabetes mellitus requiring pharmacologic treatment of hyperglycemia. The benefit of identifying gestational diabetes mellitus is that women diagnosed with diabetes mellitus are at high risk for developing type 2 diabetes for long term, and after giving birth to a child, the gestational diabetes mellitus treatment reduces adverse pregnancy outcomes. An important study by Sullivan and Mahan defined the specific diagnostic criteria for gestational diabetes mellitus (GDM) in US. Their criteria was based on 100-gram 3-hour oral glucose tolerance test designed to identify women at higher risk of gestational diabetes mellitus, which aimed to correlate maternal hyperglycemia with adverse perinatal outcomes. Subsequent validation studies underscored the importance of the threshold in predicting the immediate complication and long-term health risk for mother and their children. Etiology: placental hormone release causes marked insulin resistance. The hormone that is the placental hormone which causes insulin resistance is lactogen. It is important to note that the lactogen causes insulin resistance in person who is genetically predetermined for gestational diabetes mellitus. As in normal pregnancy, this hormone is known to increase insulin secretion, beta cell proliferation to regulate maternal hyperglycemia. Another factor that promotes abnormally increased insulin resistance is the obesity of the mother during early in the pregnancy due to higher free fatty acid levels, which inhibit maternal glucose uptake and stimulates hepatic gluconeogenesis, that is the synthesis of glucose from the fat. This hormone is capable of provoking alteration and modification in insulin receptor also. So what the hormone does, that is lactogen does, is it alters and modify the insulin receptor. Initially, it starts initially what it does is at molecular level, it alters the beta subunit of insulin receptor. It also diminishes tyrosine kinase phosphorylation, which activates the receptor. It remodels insulin receptor substrate 1, which is important for the signaling phosphatidylinositol 3 kinase. This is also important for signaling, which ultimately leads to diminishing, that is the decreased glucose uptake by the tissues. Maternal pancreatic beta cell dysfunction resulting in decreased insulin secretion, which results in inability to control insulin resistance and increased glucose level. Evidence of genetic etiology has been found in some gestational diabetes mellitus study in which association between type 2 diabetes and genetic mutation has come to focus. Several studies have found genetic predisposition, including MTNR1B gene, which encodes for melatonin receptor 1 protein, TCF7L2 WNT signaling pathway, HKDC1 hexokinase domain containing 1, GCKR, that is glucokinase regulatory proteins, IRS1 insulin receptor substrate 1, PPP1R3B function in liver to control glycogen synthesis, which are involved in functions such as insulin secretion, glucose metabolism, insulin resistance in patients with type 2 diabetes associated GDM. So these genes particularly are directly or indirectly linked with glucose metabolism. Epidemiology and pathophysiology. Here, the International Diabetes Federation estimated that globally 1 in 6 live births had a gestational diabetes mellitus diagnosis. In US alone, 7% of pregnancy were complicated by diabetes of any type, with 86% having GDM. The estimated prevalence of GDM in Europe was 10.9%. Physiological increase in circulating placental hormone lactogen, including growth hormone, corticotrophin releasing hormone, human placental lactogen, prolactin, estrogen, progesterone, increased insulin resistance during a normal pregnancy. The risk factors. The following clinical factors are associated with gestational diabetes mellitus: increased body weight, that is BMI index is high, body mass index is higher than 25 or 23 in Asian Americans, decreased physical activity, first degree relative with diabetes mellitus, be it your father or mother, high risk ethnicity, that is African American, Latino, Native American, Asian American, Pacific Islanders, past history of any of the following, that is in gestational diabetes mellitus, newborn birth weight of greater than equal to 4,000 grams, that is 4 kg, cardiovascular diseases, hypertension, low high density lipoprotein, less than 35 milligram per deciliter, or a triglyceride level greater than 250 mg per dl, polycystic ovarian syndrome, hemoglobin, acetylated hemoglobin greater than 5.7. Sorry, it's not acetylated, but glycated. That means hemoglobin packed with glucose, abnormal oral glucose tolerance test, any significant marker of insulin resistant acanthosis nigricans. Acanthosis nigricans is basically a skin condition characterized by dark patches in body folds. GDM is primarily identified by screening tests in pregnancy. The American College of Obstetricians and Gynecologists recommended targeted evaluation of type 2 diabetes early in pregnancy with a 75-gram or 50-gram oral glucose tolerance test in patients who have a body mass index of 30 kg per meter square or more, and one of the following risk factor, as discussed before, that can be history of gestational diabetes mellitus, hemoglobin glycated greater than or equal to 5.7 on previous test, immediate family member with diabetes, cardiovascular disease, hypertension, and so on. Treatment and management. GDM management begins with non-pharmacological approaches such as higher physical activity, dietary change, glucose monitoring. The amount of exercise recommended in patients with GDM is 30 minutes of moderate intensity aerobic exercise at least 5 days a week, or a minimum of 150 minutes per week. The EDA and AOG suggest a glucose target of less than 95 milligram per deciliter fasting, 140 milligram per deciliter post-prandial, or less at 1 hour, or 120 milligram per deciliter at 2 hours. Patients are advised to keep glucose reading logs that can be reviewed when required. Insulin do not cross the placental barrier, but recommended by American Diabetic Association for first-line treatment of gestational diabetes mellitus. The most commonly given oral hypoglycemic agents include metformin, which is given 500 milligram dose daily and maximum of 2500 to 3000 mg, glyburide 2.5 mg daily and maximum 20 milligram, Due to obstetrical risk associated with gestational diabetes mellitus, management varies depending upon multiple clinical factors. Fetal growth is typically assessed with serial ultrasounds due to the risk of macrosomia and shoulder dystocia. Macrosomia is basically a condition in which infant is larger than expected for their age and gender and has more with respect to 90% of babies of same gestational age, whereas shoulder dystocia is a condition in which baby shoulder gets stuck after the head has emerged out during vaginal delivery. GDM is an indication of antepartum fetal surveillance due to the increased risk of fetal dementia in patients with diabetes. Prognosis: proper control of glucose levels reduces GDM risk, including macrosomia and neonatal hypoglycemia. The risk of preeclampsia decreases from 18% to 22% with treatment. Preeclampsia is basically a condition in which the blood pressure is dangerously higher. Coming to the complications, maternal and fetal complications are both associated with GDM. The fetal complications include macrosomia, neonatal hypoglycemia, polycythemia, shoulder dystocia, hyperbilirubinemia, that is increase in bilirubin, and neonatal respiratory distress syndrome, increased perinatal mortality, and hypocalcemia, decrease in calcium. Maternal complications include preeclampsia, increased risk of developing diabetes mellitus after delivery, increased risk of cesarean delivery. Patient education includes appropriate diet change and knowledge regarding that, exercise, lifestyle modifications. Further, regular follow-up care is crucial, including repeated screening every 1 to 3 years if initial postmortem results are normal. Continued lifestyle interventions and dietary changes are proven effective in diabetes prevention program, play an important role in managing potentially preventing type 2 diabetes in high-risk populations. So thank you, like, share, subscribe, and comment.